Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
Welcome to JACC Interventions. I'm Dr. Skip Anderson from Houston, Texas, Associate Editor for JACC Interventions, and I'm here today with Dr. Akiko Mihara, the Director of the Intravascular Ultrasound and Physiology Core Lab at the Cardiology Research Foundation in New York City. And we're here today to discuss her paper in conjunction with her colleague, Dr. Zherbo Liu, entitled Volumetric Intravascular Ultrasound Comparison of Early Drug-Eluting Stent Thrombosis versus Drug-Eluting In-Stent Restenosis. Welcome, Dr. Mihara. Could you tell us, please, what was the research question that you set out to study in this investigation?
Okay. We would like to know who is going to stent thrombosis, who is going to in-stent restenosis, and who is not, using IVUS measurement.
Okay.
That is our question, yeah. Mm-hmm.
So the question was some predictors or correlates of in-stent thrombosis versus in-stent restenosis. Okay. And how did you choose the patients in order to investigate this question?
Yep. Because of the stent thrombosis cases is not so much, we pick up consecutive 20 definite stent thrombosis with IVUS and pick up 50 in-stent restenosis and pick up 50 non-event cases with IVUS imaging.
I see. So you had 20 consecutive in-stent thrombosis, stent thrombosis cases, and then you were able to do some matching from your database and obtain 50 patients with in-stent restenosis and another 50 patients with no events. So you must have had paired, for the most part, paired ultrasound measurements from before to after in order to make these comparisons?
Yes. Most of the patients for in-stent restenosis and no-event cases, we pick up the IVUS image at follow-up. For the stent thrombosis cases, 40 patients we have IVUS image at follow-up only. 4 patients we have baseline and follow-up. 2 patients only baseline image, but because because the stent will not record, then we can assume baseline and follow-up image should be acceptable to answer this question.
I see. So you had 3 different groups then. You had the group of 20 with stent thrombosis, the group of 50 with in-stent restenosis, and the group with no events. And these were mostly early stent thrombosis cases.
And 70 patients out of 20 stent thrombosis cases happen within 1 month, so-called acute stent thrombosis.
Right. I think the average was 9 days from stent implantation. So these really were early stent thrombosis cases.
Correct.
And the in-stent restenosis occurred about how long after implantation?
8 months, 8.3 months.
So about 8 months for the in-stent restenosis group. And as I recall, it was about the same amount of time, 8 months, on the patients who had no events.
Yes.
Okay, so what did you learn in the comparison between these groups?
Compared to the minimum lumen site only, in-stent restenosis, stent thrombosis, similar. But if we compare volumetric, such as how diffuse and the expansion or not, diffuse and the expansion is more obvious in stent thrombosis cases. That is most important message.
I see. So the underexpansion, there was more diffuse underexpansion of the stents in the cases with thrombosis, and then some intermediate level for the in-stent restenosis, and then least of all in the patients who had no events.
Correct.
So there was a gradation across the 3 groups.
Yes.
Clear gradation that was important. I see. So what do you feel is the important take-home message then for the interventionalist?
At the cath lab, when you check the IVUS, if stent is diffusely under expansion, be careful to think about very acute stent thrombosis. Not only the minimum lumen site, we have to be careful good expansion all of the stent segment.
Okay, so good expansion throughout the length of the stent. So the message of this particular investigation then for practicing interventionalists is to try to avoid underexpansion and try as much as possible to achieve optimal full expansion of the stents throughout their length. Well, thank you very much for visiting with us today, Dr. Mihara.
Thank you very much.